Thank you, Deepak sir. Deepak sir and Kalita sirs are like my elder brother. And my second home, always people say your second home is Northeast. So really, I admire my second home is Northeast, and I love the reception and love given by them to me. Thank you very much, Pranav, for calling me for this lecture. And today, it's a very important topic because it is not the problem of Northeast, it's even a problem of Delhi. The approach to a management of STEMI who are presenting late. Now, that is very, very important. Why it's important? Because in a management of STEMI, the time is important. As soon as you revascularize, it is a more better mortality and morbidity. And if you are late, the benefit of all treatment goes away. We have made a lot of advantage in advancement in last 2 decades. And it has reduced tremendous morbidity and mortality in management of acute STEMI. But the late presenter is a still major problem, even in Western country, because the data says that even in Western country, approximately 15% of the patients present with a late time. How you define late presentation? The late presenter are invariably defined if we are presenting more than 12 hours after the onset of the first symptom of STEMI. So the 12 hours is the basic, the time period beyond which you are defined as a late presenter. However, in our setup, significant number of patients came after 48 hours. Even in our AIIMS, we have seen the patients who present after 2 days without any treatment. The major issue in defining the rate presentation is a reperfusion therapy because all rest therapy is same. So it is a reperfusion therapy which is important, whether to give, whether to not to give in the late presenter. Now, if a patient present more than 12 hours, there are 4 phases of management of STEMI. First, pre-hospital management, a hospital management and discharge. And the most important thing is follow-up advice and rehabilitation of these patients. When a patient presents after 12 hours, the first and foremost thing is that you have to have an ECG. If you are presenting with an STEMI within 12 hours, the guideline says that you should have an ECG done within 10 minutes of arrival to your casualty. But I don't think any guideline mentioned that the ECG for a late presenter should be done within 10 minutes. However, I will always recommend do an ECG as soon as possible. Even a patient who are presenting late, keep that patients in an ECG monitor bed with a defibrillator capacity. And you have to take the blood sample for additional serum markers and other tests. The additional ECG for a right ventricular infarct, for a posterior wall infarct need to be done in all these patients. On the right side, the guidelines are the patient who presented early. So I have made 2 important things that the guideline says basically of early presenter, but what we should do in a late presenter, what a guideline says, what are the evidences. However, I always say that these guidelines are applicable to the late presenter. Only the revascularization therapy, there is a debate. Now, as far as oxygen is concerned, even a patient who has, because the guideline says that if your saturation is less than 90%, you should have, it's a class 1 indication to give oxygen. Now, if your saturation is not more than 90, is more than 90%, you don't require to give oxygen. There are a lot of studies which say that these oxygen may be harmful. However, the previous guideline, this is an European guideline. However, the previous American guidelines says that all patients of MI who has presented should be given oxygen for 3 hours. As far as late presenter is concerned, I will always say that if their saturation is less than 90%, only give the oxygen to them. Sedation, yes, a late presenter may have an anxiety, they may have an pain, so you have to give a proper sedation and painkiller it's a class 2A indication. However, I recommend that all patients who presented late, if they are having any chest pain, if they are having any anxiety, you have to give opioid for the relief of pain and mild tranquilizer for their anxiety. There is no controversy. Within 6 hours, all guidelines says that the thrombolytic therapy or a primary PCI should be done. From 6 to 12 hours, the recommendation is that if a patient presented with STEMI between 6 to 12 hours, all are class 1 indication. You have to revascularize this patient either by thrombolytic therapy or a primary PCI. There is no debate. The literature says that is a class 1 indication. Now the controversy starts. If you have a late presenter, means you have presented more than 12 hours of the onset of the symptom. What is the current status of thrombolytic therapy? The European guideline says that after 12 hours, they have not mentioned thrombolytic therapy as the treatment option. However, this European guideline has come, the last guideline has come in 2017, but the American guidelines, which is last American guidelines, is published in 2012, and there is an upgradation later on. They recommend that if a patient of STEMI presented more than 12 hours and less than 24 hours, and if they are having ongoing symptoms, hemodynamic unstable, and there is a large area of myocardium at risk, you can give thrombolytic therapy in these patients. And it's a class 2 indication. Class 2 indication means in our setup, if a patient comes beyond 12 hours with a chest pain, with a hemodynamic instability, with an ongoing ischemia, large area of myocardium, we should give thrombolytic therapy if primary PCI is not available. And once you have given a thrombolytic therapy, try to shift this patient to PCI capable facility. However, if patient is asymptomatic, he is not hemodynamic unstable, the thrombolytic therapy with after 12 hours has no role, and there's no evidence that in these patients you should give thrombolytic therapy. Beyond 24 hours, you should never give thrombolytic therapy in an asymptomatic patients or patients who are presented beyond 24 hours of onset of symptoms. Now, these are the evidence. The first evidence is in 1993, a late trial. Late trial has included 6,000 patients and compare patients who and given Antiplatelet, which is beyond 12 hours from symptom onset. And they have concluded that there is an ample benefit within 6 hours. From 6 to 12 hours, still there is a benefit, but beyond 12 hours, there is no benefit when you thrombolize these patients. A subgroup analysis of the late trial says that if there is an ongoing symptoms and a significant electrographic changes, still giving thrombolysis has 22% reduction in mortality, but it should be within 24 hours. The ICES-2 trial, which is published in 1988, it also shows that reduction is mortality by 19%, though it's not statistically significant, in a patient who receive STK between 12 to 24 hours if they are having symptoms or they have having hemodynamic instability. Again, this is an AIIMS trial published in 1993, 4,000 patients included up to 24 hours. And what they say, beyond 6 to 12 hours, there is a benefit, but it is not statistically significant. But after 12 hours, giving thrombolysis, there are no benefit in patients, even they are having a symptom or hemodynamic instability. Then come a primary PCI beyond 12 hours. So now it's very clear that the thrombolytic therapy should not be given beyond 12 hours. However, there is subtle evidence that if they are hemodynamic unstable and if they are having ongoing chest pain, they can be offered primary thrombolytic therapy. And I recommend that in our setup, where primary PCI facility is not available, we should give thrombolysis in a subset of people beyond 12 hours up to 24 hours who are having ongoing chest pain or hemodynamic instability. But what about a primary PCI? Now, these are the recommendation of European Society, which is equally within American Society. They say that in patient with time from symptom onset more than 12 hours, a primary PCI strategy is indicated in all patients who are having ongoing symptoms, hemodynamic instability, or life-threatening ventricular arrhythmia. So it's a class 1 indication, no doubt about it. And these are all evidences. These evidences came in 2011 with PLACS study in which they have recruited 2,000 patients, presented 12 to 24 hours, and they say that invasive approach has lower mortality after 12 months than patient with conservative approach. And what they say that if a patient presented from 12 to 24 hours, even though they are asymptomatic, a primary PCI may lead to mortality benefit. And this is again a study was published in 2009, early study. Infarct size and myocardial salvage after primary angioplasty in a patient presented with symptoms for less than 12 hours and from 12 to 72 hours. However, it's not statistically enough powered study, but it says that final infarct size is larger in late presenter. It is very obvious. And when you revascularize this presenter, it can limit the infarct size. Now, this is again a study which is published in 2005. Mechanical reperfusion in patient with acute myocardial infarction presenting more than 12 hours from the symptoms onset. They have not a very huge population, about 365 patients, which is known as BRAVE-2 study. What they find that the final left ventricular infarct size was significantly smaller in patient assigned to invasive group if they are late presenter without any symptoms even. And the secondary endpoint of death, recurrent MI or stroke at 30 days occurred in 8 patients in invasive group and 12 patients in conservative group, though it is not statistically significant. It is showing trend toward the benefit of invasive arm. So what they have concluded, an invasive strategy based on coronary stenting with adjuvant use of abscisic reduce infarct size in patient with acute STEMI without persistent symptom beyond 12 to 48 hours after symptom onset. And they have a 4-year follow-up, which again shows that in these patients, it is a mortality benefit what they have found. However, this study is not statistically empowered to say this. Now, this is again a study, a Korean study, long-term outcome of patient with late presentation of STEMI. It's about 13,000 database in which about 600 patients are late presenter. And what they concluded, obviously, late presenter had remarkably worse clinical outcome than early presenter, even they are revascularized in the subset. So what European guideline has recommended at present, a routine primary PCI strategy can be considered in patient presenting late between 12 to 48 hours symptom onset. And this is if you have no symptoms, you have no instability, you have no hemodynamic instability. So now this is a difference between an ACC guideline and a European guideline. ACC guideline don't recommend it, but the current European guideline recommend that all patients who has in the STEMI not thrombolized, if they present late, you can do a routine PCI in this patient. It's a class 2 indication. However, beyond 48 hours, if you do an angiogram and there is a complete occlusion of the artery, you should not open until there is ongoing ischemia or there is hemodynamic instability. It's a class 3 indication. And this is depend upon the O trials, occluded artery trial investigation, which has included a huge amount of patients, follow up for 4 years. And they find that in these subset, after 3 to 28 days, if you open the infarct-related artery, if patient is not having any angina, hemodynamic instability, they have a worst outcome. So at present, after 48 hours, if you have done an angiogram, it is an occluded artery, there's no ongoing ischemia, there's no instability, please do not open the artery because these patients will have a worst outcome. Now, this is a very important study. Percutaneous coronary intervention for late reperfusion after myocardial infarction in stable patient. This is a meta-analysis. This meta-analysis included the O trial also. So again, this meta-analysis says there were no statistical significant difference for any clinical outcome with trend to have an increased myocardial infarction and decrease in CHF in PCI arm. The PCI arm shows a slight superiority in left ventricular ejection fraction, and that was shown in a smaller unrandomized previous study. But after this OAT study, it is very clear that after 48 hours, if patient is asymptomatic, please do not open this artery. It may have an adverse outcome. So this is in current a guideline at present, which I think everybody is following. From 12 hours to 48 hours, if patient is having symptoms, hemodynamic instability or arrhythmia, you should perform a primary PCI. If patient is asymptomatic, a routine primary PCI from 12 to 48 hours is class 2A or B indication. Still, it is recommended if you are doing it, is you are not harming the patient. However, beyond 48 hours, if there's no symptoms, no hemodynamic instability, no arrhythmia, routine PCI will harm the patient. So it's a class 3 indication. Now again, that is very important because it is challenging the recommendation given by all the society. This is a recent study. I think it's published in 2018. What they have done the medical magnetic resonance imaging, MRI imaging in these patients. The patient who presented beyond 12 hours, they have undergone primary PCI. So they have done an MRI imaging within 72 hours and then 30 days. What they have found, that patient who presented late and presented within 12 hours, though they are in fact the equal area of risk, the risk in which myocardial is jeopardized is equal. However, the late presenter has larger final infarct size, even if they underwent primary PCI. It is obvious. If you perform early, there will be less myocardial. If you perform late, there will be more myocardial damage. It is obvious. But what they have done, this is the most important thing in this study. STEMI patient with sign of ongoing ischemia treated with primary PCI 12 to 72 hours after symptoms onset had less myocardial salvage and developed large infarct. That is obvious, and we all can understand that late. But what they have said, however, a large proportion, 2/3 patient who are presented late has substantial myocardial salvage, indicating a benefit from primary PCI in late presenting patients. So they say even they have a large infarct, they have a less salvage. If you do a PCI in a late presenter, depending upon MRI study, you are able to salvage about 65% of the patients. This is also a Swiss study in which they have done a PCI after 1 to 3 months, asymptomatic patients. And what they find 200 patients, that if they are having a asymptomatic ischemia, and they have defined asymptomatic ischemia, they have done a treadmill test. In treadmill, if they are in STT changes and they have no symptom, they further underwent a cardiac nucleotide imaging or a stress echocardiography. If they are showing positive without any chest pain, then they have included the patient. So out of 1,000 patients, they are only able to include 200 patients. They are entirely asymptomatic ischemic patient. And if you perform PCI, they have a less sudden cardiac death. They have a less LV dysfunction in the long term. So it's very, very important. So I think at present, seeing all the guidelines, this should be the recommendation which I should give, that late STEMI presenter after 12 to 48 hours, if they are hemodynamic unstable, they should straightway go to primary PCI, percutaneous coronary intervention. Now we cannot say primary PCI, but if they are not hemodynamic unstable, but still having sign and symptom of ischemia, they should go for a percutaneous coronary intervention. If they are not having signs and symptoms of ischemia, assess timing. It means if they came within 12 to 48 hours, the European guideline says that they should go for percutaneous coronary intervention. But if they are more than 48 hours, I think you require a stress test imaging. If a stress test is negative, you should not subject to these patients for PCI. But if a stress test is positive, then you should subject them for a primary PCI. Otherwise, you should have a medical management in this patient. Now, if PCI is preferred in these patients, what are the problems you are going to face? These patients who are presenting late have more thrombus burden, believe it. So there is more chances of no flow and slow flow. So you should be prepared for that. You should have all the instrument, all the medicine for preventing of no flow or slow flow. So that is a very important thing. Now the debate starts whether you should only touch the infarct-related artery or you should do a multi-vessel PCI. So at present, if you say me, even though because the literature at present say when you are doing a primary PCI in a patient who are presented less than 12 hours, you only want to touch the infarct-related artery. You don't want to touch a multi-vessel. However, at present, I still recommend if a primary PCI, if a PCI is done in a late presenter, you should only touch the culprit vessel at first. And if possible, you can do a revascularization of these patients later on, preferably before discharge. Deferred stenting is not recommended in a late presenter STEMI patients. Now, what are other therapy? You have done a reperfusion therapy. I think reperfusion therapy has its own role, but other therapy is very important. What about the antiplatelet? If you have a late presenter, the guideline says antiplatelet who has come early. But I say all these guidelines for antiplatelet fixed with a late presenter. You have to give aspirin to all these patients until this continues. You have to give clopidogrel if these patients are not going for a PCI. If you are not going for a PCI, late presenter, you don't think that these patients should be thrombolyzed or sent for PCI, you should load with them with clopidogrel, 300 milligrams. If you are not taking for PCI, don't give ticagrelor and prasugrel. It is not recommended even in late presenter. No role of upstream GP2 inhibitor. If a patient after 12 hours comes to you, he is not having any symptoms, don't load with GP2 inhibitor. It has no role. Anticoagulant therapy. I think I will follow anticoagulant therapy as I was following early presenters. So if they are late presenter, you should give unfractionated heparin or enoxaparin, and this should be given for the hospital stay or if you are going to take this patient for PCI. So unfractionated heparin should be given in all these patients. Now, what are the doses? I have given this slide, but I'm not going to read this slide. Only two things I just want to say. If the patients late presenter are not a candidate for either a thrombolysis or a primary PCI, aspirin plus clopidogrel should be given, no prasugrel, no ticagrelor. And the dose of clopidogrel should be 300 milligram loading followed by 75 milligram orally. If these patients are for thrombolysis, there are a very small subset of patients from 12 to 24 hours who require thrombolysis, please give clopidogrel only. Do not load with them prasugrel and ticagrelor. And the dose of clopidogrel is still 300 milligram. But if you are going to thrombolyze this patient, the age is more than 75, loading dose of clopidogrel is only 75 milligram. Don't load them. However, if these patients are being taken for a PCI, the ticagrelor or prasugrel should be preferred. However, I can say you, I am now going to write an editorial on this. Clopidogrel still hold the place. Don't forget the clopidogrel. If you are giving clopidogrel, even a patients who are going for intervention, you are not doing a crime. So if you have a practice of giving clopidogrel, continue it. However, the loading dose of clopidogrel should be 600 milligrams, not 300 milligrams. What about the NTG, IV NTG? if a late presenter has a heart failure, uncontrolled hypertension, ongoing ischemia, I think IV nitroglycerin should be given. And how long it should be given, there's a lot of debate in this literature, even in early presenter, but I will say that at least for first 24 hours to 48 hours, if you are giving IV nitroglycerin, you are not doing a crime. Beyond that, until there is the compulsory indication like ongoing ischemia, uncontrolled hypertension, heart failure, I think routine beyond 48 hours has no role in these patients. And the evidences are not ample, but there's a small studies. And beyond 48 hours, if patient is not having any ischemia, nothing else, you have done a primary PCI, continuing oral nitrates is perfectly a physician dependent. If you say me, I will still like to continue oral nitrate for 6 weeks. So there's no literature, no evidence, no recommendation. Then what is the role of beta blocker? These are the recommendations who has presented early, but I think these recommendations hold true for late presental also. Beta blocker, especially the oral, I don't think that IV beta blocker should be given in late presenter. The oral beta blocker should be considered during hospital stay and continued thereafter in all patients if it's not contraindicated. I will not recommend IV beta blocker in these patients who are presented late until they are having tachycardia, uncontrolled hypertension, there's recurrent VT, VF, and there's some compelling indication of beta blocker. Regarding ACE inhibitor, all the standard criteria for early presenter implies on late presenter. So ACE inhibitor should be considered in all patients in the absence of contraindication. If they are having heart failure, if they are having diabetes, anterior infarct, it is a class 1 indication. However, if they are not having the heart failure or diabetes, still it's a class 2 indication. If you have to ask me, if it's not contraindicated, the blood pressure is not less, they are not allergic to ACE inhibitor in the ARB, I will give start ACE inhibitor as soon as possible in all these patients. MRA, mineralocorticosteroid receptor antagonists are recommended in all these late comers if their ejection fraction is less than 40%, they are in heart failure or they are diabetics. Lipid lowering therapy, I think high dose statin to be given to all patients who are presented late until it is contraindicated. And this guideline implies to same guidelines if they are presented early. And our target, there's a lot of debate which target of LDL should be kept. And I believe that less than 70, not much less than 50. There's a lot of debate on this, that you should achieve less than 50. I will recommend less than 70 LDL in these patients. Calcium channel blocker should not be given in these patients until they are having an ongoing ischemia and beta blocker is contraindicated. And the second important indication of calcium channel blocker, the atrial fibrillation to control the heart rate. Routine use should not be given. Prophylactic lignocaine and amiodarone should not be given. Whether you are seeing a run of BPCs or NSVT on the monitor, don't give amiodarone or lignocaine. They have done more harm than doing benefit. Magnesium should not be given. Glucose, insulin, potassium has a lot of controversial role. So I will not recommend at present to give this. Then there's a complication. All the complications, because there has been a lot of study which has shown that the complication and higher in late presenter, whether it's an RVMI, tachyarrhythmia, cardiogenic shock, volume depletion, mechanical complication, heart failure or arrhythmia, they are more common in late presenter as compared to early presenter. And this should be a standard which has been seen in early presenter. Management of cardiogenic shock is very, very important, because if patient present after 12 hours, he is in cardiogenic shock. Patient present with after 48 hours, he is in cardiogenic shock. Class 1 indication, take these patients for a percutaneous coronary intervention. It's a class 1 indication. There's no doubt about it that these patients should be managed medically if you have a facility of a percutaneous coronary intervention. However, should you give thrombolysis beyond 24 hours in cardiogenic shock patient remain controversial. I have searched a lot. There's no strict data which recommended a patient who came after 24 hours in cardiogenic shock, should you thrombolize or not? I think I have left this on the discretion of the treating physician. However, you have to do one routine echo in all these patients to rule out mechanical complication. And if you have a left ventricular assist device, I think the indication is same as it is presenting early. There's two important studies. Whether if you are cardiogenic shock late presenter, you will touch only the infarct-related artery, or if you do a multi-vessel angioplasty, the culprit shock says it is basically an early presenter. It says, no, do an IRA. But the Korean acute myocardial infarction registry says, do a multi-vessel. It is still controversial. I will always say that if you have a simple type A lesion in other coronary, they presented late. If you tackle immediately without a very minimum contrast, do it. But if it's a complicated, complex lesions, don't touch, only do the infarct-related artery angioplasty. If you have an atrial fibrillation, I think the indication, the treatment is same as if atrial fibrillation has occurred in an early presenter. If you want to control the rate, beta blocker is a class 1 indication. Digoxin you can give, and IV imidazole is a good option. Please do not give IV calcium channel blocker in these patients. They sometimes have done more harm. Don't hesitate to give IV amiodarone, because IV amiodarone in acute condition is not as harmful as calcium channel blocker. And if you want to do cardioversion, the patient is hemodynamic unstable, he is having severe chest pain, his heart rate is too high, he is in LVF, please do immediate cardioversion. Don't wait for the drug therapy to act. Do an immediate cardioversion in these patients so that the AF can be controlled. What happened in a late presenter who has presented with ventricular arrhythmia? If they have a ventricular arrhythmia, they have a ventricular storm, the beta blocker is a drug of choice, not a lignocaine and amiodarone. And in a beta blocker, IV propranolol is the treatment of choice. So if the patient has a ventricular storm, try to give beta blocker. With beta blocker, give an xylocaine, give an amiodarone, give an IV magnesium. If patient is not, take them for immediately revascularization, put an assist device, or ventilate them with a propofol deep sedation. So these all are for ventricular storm, but beta blockers should be the drug of choice in these situations if they are having a ventricular arrhythmia, followed by immediate revascularization. Prophylactic use of anti-arrhythmic is a class 3 indication, and if a patient is asymptomatic and hemodynamically irrelevant ventricular arrhythmia, it should not be treated with anti-arrhythmic drug. So if you are seeing a VPCs on monitor in a late presenter, please do not give beta amiodarone or xylocaine. If you want to give beta blocker in these patients. And for a long term, it is a standard therapy for ICD. If they have ejection fraction less than 35%, more than 6 weeks of MI, and they are revascularized, you should give ICD. But the second part is very debatable. Suppose you have a ventricular arrhythmia on 4th day of MI. What will you do? Patient is not having ischemic symptoms, but he is a ventricular tachycardia. The recommendation says for 40 days, give them wearable ICD, and I will say in our setup, it is easy to give an implantable ICD than a wearable ICD. So this part in India, I will always say, if they are having requested as tachycardia, which is a secondary ventricular tachycardia, not a primary ventricular tachycardia, after 48 hours of MI, and you have revascularized these patients, given optimal therapy, I think ICD should be considered in these patients before 40 days of MI. So don't hesitate to give ICD in these patients. After that, the secondary prophylaxis means control of risk factor, lifestyle modification, smoking cessation, weight reduction, regular physical exercise, optimal control of blood pressure and diabetes, then dyslipidemia, dietetic therapy, exercise should be considered equally as they have presented early. And after discharge, I think these patients should be kept on dual antiplatelet, at least for 1 year. Beta blocker should be given indefinitely. ACE inhibitor should be given indefinitely. Hormone replacement therapy in post-menopausal women, calcium channel blocker should not be given. Nitrates if you are suspecting an ischemic symptom. Anticoagulation, yes, at present if patient is in atrial fibrillation, you have to give triple drug therapy, DAPT with anticoagulation at least for a month, and then you can convert anticoagulation with clopidogrel. Rehabilitation of these patients is very, very important because rehabilitation has shown to improve the morbidity in these patients. Rehabilitation means you have to early mobilize these patients, don't make them bedridden, because early mobilization is very important, and at present early discharge is also important. This sexual counseling is often overlooked in these patients, should be considered strongly. The psychosocial factors should be taken, and ideally there's a study that in these patients, post-MI patient, at least 50% will have moderate to severe depression. So a good psychosocial counseling of these patients, I think, should be made mandatory because it will improve the drug compliance, it will improve your advice and patient follow-up. Lifestyle modification, it is being seen that up to 80% of coronary artery disease patients attributable to modifiable risk factor like tobacco, sedation, sedentary lifestyle, obesity, diet. As far as diet is concerned, whether you should take more fat and more carbohydrate, it's a very debatable topic. I always say that if you are taking more fat, take natural fat. Take God-made fat. If you take more carbohydrate, take God-made carbohydrate. It means the fat which is available in a nature should be taken. The carbohydrate which is available in the nature should be taken. It means what fat, what carbohydrate a man has made should be avoided in this patient. Simply means a simple sugar, a simple thing should be avoided. The dalda, the refined should be avoided. You should avoid a saturated fat and trans fatty acids. So these should be avoided in these patients. So to conclude my talk, I can say latecomers after STEMI, that's more than 12 hours, with evidence of ongoing ischemia should be considered for primary PCI and even a thrombolysis in our setup. Delayed PCI more than 48 hours in asymptomatic stable patient should not be done. It is a class 3 indication. In a latecomers after STEMI who are asymptomatic, stress test can help guiding us for invasive management. However, there's no data, ample data, but I will always say do an stress test in these patients. If positive, take them for angioplasty. If not, please do not try to take them for a percutaneous coronary intervention. And it is important to have a high index of suspicion for mechanical complications. That is very, very important, because if you don't do a proper echo, don't do this, mechanical complications are very common in late presenter, which can kill the patient. So you should be a very high suspicion that you should rule out all the mechanical complication. And I will say, still it is very confusing. Still after my talk, I am still confused, and the individual patient should be taken individually, and it should be guided by the therapy, by the armamentarium, which is available in particular part of this country. If it is remote, I never say that take this patient for immediately primary PCI. If you can thrombolize this patient, still it is going to benefit. Thank you very much for your kind attention.